Testosterone time. You're going to love today's episode. This has taken us a long time to do. You know, we've flirted with a lot of TRT and hormone replacement clinics in the past, talked to them. We're never really satisfied until we found Dr. Rand McClain. That's who we interview in this episode. By the way, we put something together with them for Mind Pump listeners. So if you're interested in TRT or hormone replacement or want to see if you're a candidate, head over to mphormones.com. I know you're going to love this episode. Enjoy the show.
Dr. Rand, I'm super excited to have you in studio today. I'm going to give the audience a little bit of backstory on how I came across you, and it was Sal actually introduced me to you. I was already doing hormone therapy through another company, and I'd had a few months in, and I was expressing to Sal, after, I'm not really impressed with these doctors. I'm like, I know that I don't have a lot of knowledge in hormone therapy, but I have enough to understand some things. And I'd be asking all these questions of the nurses that were talking to me, and just they seemed like they didn't have any of the right answers for me. And Sal's like, you know what? Let me do some research. Let me find out who's in the space, who's doing the best job at this. And he began communicating with you, and he says, yeah, I know you're set up with this other company, but I want you to meet Dr. Rand and have a discussion with him. And it was such a great conversation. The very first time that I talked to you, you blew my mind as far as your extensive knowledge on hormone therapy. And I kind of want to start there for the audience so they can get a little bit of background. Where does all this knowledge come from? When did you start doing this, and when did you learn all about hormone replacement therapy?
Well, it's a good question, and it kind of begs the question, how do you know I have all this extensive knowledge? Because there's so much ignorance out there, right? You know, that there's a lot of still questions that have to be answered because it's not really become as mainstream as it should be. A lot of urologists now are taking over thanks to Dr. Lipschultz and a lot of his fellows, and I think urology will be the torchbearer, henceforward for testosterone replacement, and it makes sense, right? But I think we're probably 10 years off from that being in the mainstream because there aren't a whole lot of Lipschultzes out there. And while his fellows are spreading around the United States, I still think, we'll be in business at least for another 10 years because it's just not everywhere. And boy, when you talk about the ladies, OBGYNs, I don't think have picked up the slack. So we'll be in business with them, for even longer, I'm sure. But where it got started was really, in sport. I've always been fascinated by trying to be able to do better at sport and repair my body. I was kind of a sickly kid. They took out my tonsils when I was pretty young because that was the thing back then. If you're sick all the time, well, must be those tonsils. Mm-hmm. So they yanked those early. You too, right? Yep. And, I got interested in nutrition because I was fascinated by the fact that you could control a lot of how you feel and how you perform with the use of nutrition. And then, you started reading about anabolic steroids, not so much testosterone back then. The hullabaloo was about anabolic steroids. In the 80s, I think Sports Illustrated came out with an article that 85% of the NFL players were on anabolic steroids. So, of course, you go, okay, yeah, I want to be bigger, stronger, faster. I had Olympic aspirations. And so I was just telling you before, I can remember in high school wrestling one season and being able to dish rag one of my teammates. And then after summer, he came back 30 pounds heavier and was tossing me around the mat like I was a dish rag myself. So, they're telling us that it didn't work was falling on deaf ears because clearly it worked. And, that sparked my interest. Now, smash cut to many years down the road, I got into medicine myself. And it was easy to start practicing because one of the physicians I started with was already doing it. And with all due respect to him, I didn't think it was the best way of doing it. And I guess I skipped a long period of life where I was experimenting with these things myself, whether it would be testosterone, but mainly, anabolics back in the day. And of course, we were doing it different too. Not to start rambling on to another question here, but back in the day, stacks weren't the big deal. We couldn't afford them; they weren't available. So, we got to know, for example, decadurabolin by itself and what it would do, and just like, maybe some of you guys could do. You could tell a Cuban cigar from a Dominican Republic cigar because it had a different flavor. Because we were using them separately, we knew, okay, well, this is definitely real Deca. because of the side effects or the things that came with it, or this is real Dianabol, et cetera, et cetera. But a lot of the knowledge, to answer your question, was picked up along the way from use. And, look, the gym and bro science has its negative aspects, no doubt about it. But it's also a great petri dish for what works. Now, the explanations for why it works are often just, you go, okay, you skip physiology class, I can tell, and some biology and other classes too. But again, it's one of the most stringent regulators of some of these things, because it either works or it doesn't. You either pick up the weight or you don't, or you lift it over your head, a heavy weight or not, is what I mean to say. So the proof is in the pudding, and they're some of the harshest critics in the gym. So, I learned a lot in the gym from fellow athletes, is what I'm getting at. And then again, for my own use.
What was as your journey into educating yourself about this, what were some of the first big misconceptions that you learned?
Well, like I said earlier, that it doesn't work, that, you become impotent and your willy's going to fall off one day and all that kind of stuff. I mean, just some of the stupidest stuff you'd ever heard. And then it's going to, you're never going to come back once you use anabolic steroids. Your own endogenous production will never return. These are the things that are still perpetuated. I mean, you wouldn't believe some of the things you can still hear from, and I don't mean to be picking on anybody, but at the same time, I don't want to let anybody off. There are no excuses anymore. There's plenty of information published out there, even though it's not taught in medical school, as far as I know, to this day. It wasn't when I was in school. But doctors will still say that, for example, testosterone, just using testosterone in a replacement fashion will raise your hemoglobin hematocrit, okay, and your red blood cell count. That's not true. If you've got someone who might be I call them an expensive date, who has to use more than the typical amount of testosterone because they break down the ester, for example, and they metabolize it quickly, and we're using more than a typical replacement dose, well, then you might spike your hemoglobin hematocrit by maybe a half a point.
Oh, wow.
Maybe.
That's not a big deal.
Well, this is what this is what you said to me. I'll never forget when we had that first conversation, and you made that analogy to me, and I thought that was really funny, because I thought the opposite was going to be true with my situation. I thought that I would need more testosterone because I abused it so much in my 20s, and that's why I'd be an expensive date. And you broke it down differently to me. Explain what makes somebody a quote-unquote expensive date.
Just the way you choose your parents. I mean, it's really just luck of the draw. I've had guys that are, we call them steroidians, for 30 years that come in for replacement therapy and could really, if they wanted to, probably get away with injecting, 200 milligrams per ml of testosterone cypionate, which is a typical starting dose, every 9 or 10 days, because they metabolize it very, very slowly. So it's not necessarily what you did before. Now, your liver can accommodate in certain ways and make more or less aromatase. That's more of a factor based upon, prior use. But even then, prior use, we're talking about, months ago, not years ago, because your liver will adjust to some of the, for example, foods you eat and some of your lifestyle factors to either produce more or less aromatase. But yeah, what you did before is not really as much a factor, certainly, as people think. And just to follow up on the testosterone thing, because I think it's important for people to know, elevating your hemoglobin and hematocrit. What typically is the case is, more times than not, it's sleep apnea. In other words, the testosterone can leverage hemoglobin and hematocrit production, right? Red blood cell count. You need it. People who come in with really low testosterone will often have low hemoglobin and hematocrit, and can be even anemic because of it, which just means you're below normal hemoglobin. But it's not, testosterone in and of itself doesn't cause a problem unless you're going to really high dosages. It leverages it, though. So we see sleep apnea a lot, especially everyone in here probably got a mild form of sleep apnea. I'm looking at everyone's neck, right? We got muscly guys in here. And typically a good ear, nose, and throat doctor will look at you and go, oh, your neck is at least 17 inches. You probably have some obstruction there. And as you age, things get a little, I don't want to say softer necessarily, but maybe looser. If you have a drink or two before you go to bed, or anything that might relax you, those muscles will relax more and collapse on the trachea. So you'll find this, and of course, testosterone will leverage that. That's why guys, even in the Tour de France, not anymore, of course, but they might use testosterone not because they certainly don't want to get any bigger. They want to be 6'2", 135 to be able to get up the hill, but they know it leverages the production of testosterone. Which is leverages the production of testosterone. Beg your pardon. Using testosterone leverages the production of red blood cells and hemoglobin, the oxygen carrying capacity of the red blood cell.
So, Dr. Rand, because you've been doing this for a little while, I wanted to ask you, because the attitudes towards testosterone really changed severely, and the pendulum seems to be swinging back in the other direction. Because I know in the early days, testosterone, even anabolics, they were very easy to come by when I read stories about the 1960s and 70s. Then steroids became kind of public enemy number one, which included testosterone. It was a scheduled drug, although I would love for you to correct me if I'm wrong, but of all the hormones you could potentially inject into your body, testosterone has to be one of the safer ones, especially if you compare it to like insulin and other hormones. But
absolutely.
So, and in some countries it's over the counter. But nonetheless, it became public enemy number one, and doctors were afraid or couldn't prescribe. So if you were a guy and you go to your doctor in the 1980s or 90s, they test your testosterone, it's in the floor, you're not doing very good. They're super reluctant to even prescribe it. Now we see TRT facilities are popping up everywhere. What changed in that? Like, what happened to where it was like you could not get any hormone replacement, and now it seems to be much more available?
I got a few answers because you got a few questions in there. I hope we can keep track of this and come back when I get lost on a tangent here. But I mean, starting with, any of these substances were banned as of the '76 Olympics. Okay, that's where things definitely changed.
Was that when the East Germans showed up and just crushed everybody?
Well, okay, you can blame it on them, but Al Order was given special dispensation for I think it was his last Olympics because he had been on anabolics for so long. And it was legal to compete on anabolic steroids, again, prior to 76, that, the assumption was, okay, you use them, now you're dependent upon them. So it's my understanding he got special dispensation for his last Olympics. That might be a fairy tale. I don't know. But again, the point is, it wasn't a problem until that point. And then, everything changed. Now, why it became public enemy number one, and not number one, but it was up there at the top of the list, right? I couldn't tell you. I have no idea. Why has, and I don't mean to, I'm just picking one, and I don't have a special thing in my heart about marijuana, but, we saw movies from, I guess, the 50s and 60s, Reefer Madness, and I've never seen the movie. I've just heard about it where, you smoke pot, it's going to lead to heroin addiction, and you're going to jump off a building one day and kill yourself. So why, and we know better. Well, who dreams this stuff up? With testosterone, like you say, it's probably one of the safest hormones out there. It's definitely, you mentioned insulin. Insulin can kill you. No doubt. I've never seen a case where testosterone killed anybody. Estrogen, can kill you. Certain forms of estrogen are associated with prostate cancer and all kinds of estrogen-sensitive cancers in females. So, why it became such a why it developed such a stigma, I couldn't tell you.
Alizado, was he a big part of that?
I remember that.
Yeah, they pointed him as that was a big problem with his health, was that he was a big steroid user.
Yeah, I got to be careful here because of legal reasons, but I would argue that that was not the cause of death for Alizado, and I probably should leave it at that. But there are certain stigmas with certain diseases that I think he may or may not have. And I'm speculating here. Let's make it clear so none of us get in trouble. But Lai was a great guy. I knew him from Golds, and he was a super loving guy. But if you look into some of the things that were associated with his death, it might have been something else that caused him. I know of nothing that testosterone would have contributed to the things he died of. What would that be? Brain cancer, I've never heard of a testosterone stimulating brain cancer or perpetuating it. I mean, it's just, like you said, it's a very safe hormone. So don't know about that. But then, there was 3 parts to your...
Yeah, so it was because it became like this enemy drug, and it was thrown in the category of steroids, so testosterone being technically a steroid as well. It was impossible for men to get treated for low testosterone, or people weren't even aware that there could be an issue. Now it seems like the pendulum has kind of swung where where it's people are more aware, there's more facilities available. Is this because of that there's so many men now with testosterone issues, or have they changed the laws, or what has caused this pendulum start to kind of swing the other way?
Well, I think public demand. I mean, I can tell you that, for example, I had a young lady in my office who brought her mom in. For whatever reason, they only had one car and she was along for the ride. And she was mom was in her 70s and this gal was probably in her early 40s. And she had low testosterone, was complaining of all kinds of symptoms of low testosterone. And just out of politeness, I looked at mom and asked her how she was doing. And she said, I'm fine. And I said, nothing like your daughter here, none of these symptoms. She said, no. Then 90 days later, daughter comes back with mom again for the follow-up. And I, being polite again, asked mom how she was doing. And mom wasn't doing so well. All of a sudden, she had all the symptoms that her daughter had complained of earlier. My point being that, the humans are pretty phenomenal creatures in a lot of ways. If there's nothing you can do about it, if you've got an ounce of character, what do?
You deal with it.
You muscle up and deal with it, right? So mom had been doing that because her generation, this in my opinion, did not have these options, right? Like you said earlier, it wasn't really available. Certainly not to women is a better example. And now she sees her daughter getting better and all of a sudden, well, yeah, I'd like to get better too. It's probably going on at least subconsciously. And this is typical. And I think with guys, now that we know, hey, it's not this public enemy, testosterone replacement, and my buddy down the street is using it, or my buddy in the gym is using it and doing so much better now. I can see it. That's how I found out about it. I asked him, I said, dude, what are you doing? Right. And he found out about it. So public demand is leading that charge, certainly. Okay. Also, doctors. I mean, I got a lot of patients that are doctors. They're finding out about it and they're going, well, this is a great way to help my patients. This is a great way to make a living. And come on, I have a great job. I don't have people complaining about major problems. They're not on 26 medications typically. They're people that are trying to get even better in terms of health and optimizing it. So what a great way to make a living. So more doctors are incorporating it into their practice. It's now being covered oftentimes by insurance. Even the HMOs of the world are sometimes covering it. The problem there is, to get to another problem, is before you have doctors looking at reference intervals. And those reference intervals for testosterone are very broad.
Yeah, so explain that reference, because I know I look at the numbers, I'm like, it's like between 300 and 1,200. It's like, that's a big difference.
Well, that was another thing that you blew my mind and corrected me on too, was the other place, we always talked about this generic range, right? They would tell me like, 400, I think, to 1,200 of free testosterone is this kind of optimal, or total testosterone is this optimal place to be. And I remember you telling me that, yeah, but there's other factors I'm looking at on your blood work that are actually more important. Go into that a little bit. You remember that conversation?
Yeah, no, because I have it frequently, fortunately or unfortunately. First of all, I don't know where they're getting those reference intervals from. And I see it all across assays. Nowadays, for example, you can see a cholesterol reference interval that is nothing close to whatever they want to call it, normal, because I see these assays day in and day out, and 0 to 99, I'm going to forget the units of measurement right now, in terms of, say, LDL cholesterol, is not normal. Okay, so where they're getting those reference intervals, I couldn't tell you. Unless you're on a statin or getting chased by lions on the Serengeti Plain on a daily basis, you're not seeing somebody below 99 typically. When it comes to testosterone, again, I have no idea where they're getting those numbers from. They have adjusted them, by the way. Some companies from that, it was like 1197 LabCorp used to have as the top of the range. That's unusual. Now they've clipped it back to somewhere in the 900s, I believe. Okay. But the point is, to your point, I think this is the question you're asking. First of all, even if that were normal, so what? As I like to joke with, but make a point with my patients, it's normal to get sick and die one day. Who cares about what's normal? Yeah. One day, 0 is going to be normal for you because you're going to be 6 feet under. Nothing's working, right? Yeah. What we want to concentrate on, I would think, in medicine is what's optimal. Yeah. What's the best thing for you? So if you see someone, and this is typical, my typical patient, especially coming from an HMO or a doctor that hasn't been educated in this yet, they look at your labs and they go, okay, for example, in your case, you're saying that the reference interval you saw was 400 and above was normal. Okay, you're at 450. Big whoop, right? At the end of the day, what do you treat? The numbers or the patient? Right. If you're still having issues, complaints, then the numbers are to be used as guidance. If you had 1,100 total testosterone, and more importantly, by the way, your free testosterone was commensurate at, say, 22 picograms per milliliter, then you go, probably not testosterone that's causing you the problem. Makes sense, right? Because that's pretty flush. That's a nice level of testosterone. You might look at other reasons for a lack of energy, a lack of libido, et cetera, or lack of body composition. Quit eating the cheeseburgers all the time with the milkshake and supersize and all that stuff. You get my point,
Right.
So. That's probably the other problem that has started to change, is that doctors are realizing, the reference intervals are just that. They're there for reference and support or subtraction from a diagnosis rather than a rigid level. And one of the guys that helped that immensely was a guy named Abraham Morgenthaler, who wrote a book, Testosterone For Life, I believe was the name of the book. And earlier in his career, he had set a limit. I think it was 450, as a matter of fact, for total T. Didn't even concern himself with free T. And then finally, in an international consensus, I think from 2016, said, hey, it's not about the number. It's about the patient, which is kind of a duh, right? You would think. Anyway, things have changed because that's now published, and he's a big shot in the industry. He's got a much better resume than I do. I think he's an associate professor with Harvard, and so that's helped things a lot too, I think.
Yeah, I remember reading years ago, because obviously I've been in the fitness space now for decades, and what we used to hear all the time were the dangers of high amounts of anabolics or high amounts of testosterone. And this was popular media, how bad it is for your heart, how bad it is for your health. And then I remember reading actual scientific articles. This was a little later in my career, and seeing, and I had no idea. I had no idea that low testosterone had severe health longevity effects. Can you go into that? It's like, because I think a lot of us think high testosterone is really bad, but on the other end of the spectrum, and maybe we can get into that, like high testosterone, is that really bad? But let's talk about the low testosterone and what that could, besides feeling like crap, besides having low energy, low confidence, low libido, what are the health risks of having just low testosterone?
Let's definitely come back to the risks of high levels, okay? Yeah. But because first of all, the definition of high should be defined.
Okay.
Or undefined, at least in terms of the reference intervals that we have currently. And there's other factors that come with high levels of testosterone use in the bodybuilding community. But to answer your question, absolutely. We have studies that go back, I think as far as the 1950s, showing a correlation between low testosterone and things like coronary artery disease, type 2 diabetes, colon cancer, prostate cancer, osteoporosis, okay? And that's other than prostate cancer in both men and women.
Dementia and Alzheimer's too, I just read recently.
Which adds up, right? I mean, you can start drawing all kinds of, and again, I use the word carefully, correlations, because look, if you had low testosterone, for example, given all the other things you do for your fitness and your health, more than likely, you're not going to have an issue with type 2 diabetes, for example, or coronary artery disease, okay? Although there are other factors that play in. And that's the thing, it's multifactorial. So we're always generalizing, which is important to include in the discussion, and any discussion that's medical. Everything should be individualized. But I'm going off on too many tangents, I apologize.
No problem.
We know, generally speaking, though, that there is a correlation, and when we correct these things, life gets better and the likelihood of some of these disease states decreases. That's a given, okay? So, yeah, there have been some studies, so-called studies, that have raised the attention. And if you remember, maybe 6-7 years ago, I'm terrible with time, but on ESPN, every 15 minutes, there was an advertisement for a class action lawsuit. If you or your loved ones have been involved or been prescribed testosterone, do you remember those?
No, I don't remember that one, but I know the commercials.
I do, because he didn't watch ESPN.
Well, it was based on, I believe, 2 studies, one of which I remember, it was a VA study, which I'll just stop there, right? But no, going further, they used a cream. And by the way, the upshot of this study was it increased the risk of heart issues, mainly coronary artery disease. So one of the knocks, and I'm not suggesting that this is true necessarily, but one of the knocks on the VA system is there's very little follow through, and they in some instances, I mean, there's some great counterexamples to this, but in a lot of areas of the country, the care is not that great. So anyway, you have a guy who jumps into this study and they give him a cream. There's no way to determine if the patient was compliant. So he might have said, okay, yeah, I'll do this, and got his other meds that same day, but got maybe to the front of the line because he participated in the study. I don't know. I don't want to speculate any further than I am already. But then 3 months later comes back, applies the cream that day because he knows he's getting tested. Again, no assurance of compliance. But the treatment was ridiculous based upon what we know now. It was like, some of these, and I won't name names, but some of these branded gels and creams that, don't even have enough in them. The dosing is not even sufficient for a female in most cases. So they weren't being treated really. We can't be sure that even with the treatment they were given, they were compliant. And here's the kicker. These guys in this study were all in line for cardiac catheterization, meaning they were already heart patients. Oh. And yet it was published, in peer-reviewed journals. A bunch of us got together, and of course, once we saw this, and it takes, months, if not years, to reverse some of the stuff, objected. The study was retracted. The journal was spanked for even publishing it. And, there you have it. There you had people that were... And this is, I called one of my best buddies in the whole world who happens to be a PI attorney. I said, and it happens to be on, I'm not going to name his name because he happens to be on therapy. Excuse me. And I said, friend, what's going on here? And I started off on a rant. He says, whoa, rant. He says, it has nothing to do with the medicine. It's a class action lawsuit. That's the brass ring for an attorney. Okay. They got a lot to win and very little to lose. So that's how these things get perpetuated. And, patients of mine, either that were already on therapy or that were thinking about it are coming in and going, what's going on here? I heard it can cause heart problems. And you got to back through, over 70 years worth of research and undo all that because of one lousy, irresponsibly published study. It's remarkable. And I say 7 years because we've known since the 1950s that this stuff not only works, but is very, very safe. We've got plenty of studies that go back that far.
Wow. So now let's go back to the high testosterone fears it's dangerous to have too much, or taking too much can cause problems. Let's talk about that. Maybe, I guess, paint the context. What would you consider too much? Would it be out of range, or does it depend on the individual?
There have been no studies that I'm aware of that use dosages that we might find in your typical bodybuilder program in a prescribed, if you will, in a gym, right? So that's kind of hard to answer on one hand, but having seen all this, go on in a gym, a couple things come to mind. First of all, there's, in terms of we don't have a formal study, but even in terms of analyzing this, we don't know what those guys are getting necessarily. This is all bootleg pharmaceutical stuff, right? And based on what I've seen, a lot of this stuff is stepped on because guys will come to me and say, Doc, what comes here stays here, right? They're afraid that I'm going to report them or something like that. Yeah. And they'll tell me what they're doing. I go, that's impossible, especially based upon your laboratory assays. So there's definitely evidence that whatever they're getting in the gym is not necessarily what it's supposed to be.
Interesting.
So you'll hear about guys doing 3 grams of something a week. That's impossible. It's just not going to happen. But even if they were, back in the day, you hear stories of guys doing, and how do you substantiate these stories? Guys doing a gram or 2 of something a week. Okay, even if you were, the risks of excess testosterone or certain anabolics would be conversion to other substances like excess estrogen or dihydrotestosterone. And as you know, certain anabolics will not convert to DHT or estrogen. So even those are limited. The other risk that most doctors will talk about, and this opens up a whole other can of worms, is and it's rare you can say this in medicine, every anabolic steroid comes with side effects to raise so-called bad cholesterol, LDL, and I say so-called for a reason, and lower so-called good cholesterol. And so that's a major reason why in practice, if some doctor were to prescribe an anabolic steroid, they will typically always weigh risks versus benefits, but pull you off after, say, 3 months and watch for your lipid profile to reequilibrate. Why, I couldn't tell you. Unless you have established coronary artery disease, it makes no difference. And this goes off into another conversation about lipids and how we look at things for the last, again, 70 years incorrectly when we evaluate someone's lipid profile.
If you wouldn't mind, let's get into that, because you're saying so-called bad, so-called good. Why are you referring to them that way?
Well, there's a lot of issues with the standard lipid panel. We're looking at LDL cholesterol, and it goes well beyond that. But first and foremost, again, and it's a great timing because the people on what people call a dirty ketogenic diet, where they're using a lot of saturated fats for their ketogenic diet, you see a lot of elevated LDLs. Well, and if that were killing people, we see people dropping dead left and right, because I see people in my office on these diets that have an LDL over 200, right? LDL doesn't cause the problem, okay? LDL comes in after the problem has started, and the problem starts with inflammation. And I use the analogy of gasoline in your garage, probably. If you still have an electric lawnmower, if you don't have an electric, you still have a gas-powered lawnmower, that 5 gallons of gas is pretty useful. Okay, cholesterol is useful. After all, it's how we make cholesterol. It's how we make cholesterol-based hormones,
right.
Okay? And so they are very important until you go on TRT, then it doesn't matter so much, right? But that 5-gallon gasoline can is not going to be a problem to you as long as you're not using your acetylene torch next to it, right? Now, if you are, then you might have a serious problem, as well as maybe your neighbor. If you don't have inflammation, if you don't have an irritation inside the endothelial wall of your coronary arteries, then all the so-called bad cholesterol in the world is not going to start a problem. It will finish it for you. It'll start you off. It will not start you off. It'll finish off what you started with inflammation. Okay, and then you go into the measurements. Do we really want to look at LDL, or do we want to look at LDLP, or do we want to look at Lp(a)? These are other measurements that get into more of the brass tacks of your lipids that actually make a difference, that are more correlated.
So like these are are you talking about like the smaller or larger particle LDL particles? Is that what that refers to?
More the number with LDLP, okay. The number of particles, and then Lp(a) is another measurement altogether. And even those two are correlated somewhat. So you don't have to necessarily get both of them. You're in pretty good stead. I'm just being practical now as a physician, getting one or the other. But just getting a standard LDL is standard of care. And so legally, a lot of physicians are really, including me, are sort of forced to grab that. And okay, if I saw I saw a guy the other day with 316 LDL, I go, okay, well, you're at greater risk than someone else if you have established coronary artery disease. So it might leverage me to go into recommending, say, the starting course would be a bilateral carotid Doppler ultrasound, where they just look at your carotid arteries to see if you do have any evidence of coronary artery disease, in which the LDL would, again, make a difference. But if not, you move on. There's a 95% correlation, again, between what we see here and what's in the heart. And this isn't me making this up. If you talk to the top cardiologists, say the top 5% of the cardiologists, they'll agree. This is Stefan Room over at UCLA, best in the West, has been doing this for 20, 25 years. And guys like Mark Penn, formerly of Cleveland Clinic, will agree. Because it's not a factor, this cholesterol, unless you have coronary artery disease to begin with. So it's a good. What's your biggest risk for coronary artery disease? Like most diseases, age, right? So if you're 30 and you have an LDL of 200, am I really going to start worrying about it unless you have a first degree relative, another risk in your family that had coronary artery disease early in life? So you see, there's a lot of factors here, and again, the problem is what we're talking about here is trying to do kind of paint by numbers medicine. We all do it. We generalize. That's how we move in the right direction with medicine. But you still have to treat everybody individually.
You brought up inflammation. Is testosterone anti-inflammatory? Because I've known people who, when their testosterone is low, they feel lots of aches and pains. They feel stiff. Then they get on TRT, and all of a sudden they feel loose and not as much pain. Is that due to any anti-inflammatory effects?
I wouldn't say in a direct way. I would say in an indirect way, because you're healthier. And of course, even just, for example, stability at a joint that might be already arthritic. If you've got some more strength, put on a little muscle, and because of testosterone use and combined with, proper exercise,
yes,
you strengthen the area, then you're less likely to have when you don't want it to mobilize in the wrong directions, mobilized joint, it stays more stable and you have less pain. Definitely. I mean, I hear that all
reduced
the time.
inflammation for more strength, which we see as trainers all the time, making someone stronger, less pain because they're moving better. Therefore, and less inflammation.
Now, as with so many things, the poison's in the dose. And arguably, certainly when you move into anabolic steroids, part of the stimulation, sort of like the sand in the oyster to stimulate muscle growth is a little more inflammation. So you got to be careful to say, is it anti-inflammatory or not? I wouldn't say it's one way or the other, but with the example I gave you, I sort of skirted the answer to the question. Certainly if you had an arthritic knee, for example, strengthening the knee in most cases, or even if it weren't arthritic, if it was a loose ACL or something like that, would make for less pain.
What are some of the biggest mistakes that doctors make with TRT with their patients that you see?
Let me jump in here real quick, and hopefully you can edit all this stuff and make it more flowing. But I wanted to I wanted to touch on one thing about the excess testosterone. Okay. One of the things that comes with that, I harped on one about, okay, you're not really getting 3 grams equivalent. It's probably, a tenth of that because they step on it just like any other. I know it's not a recreational drug, but things that are sold in the street, right? What people forget is the bodybuilders, and I'm not picking on everybody, but in general, the bodybuilders of old, what were they trying to do? They were trying to become as big as possible. And even if they weren't trying to become as big as possible, today's athlete wants to be, leaner and more ripped. But what are they doing for a living? Typically, the top guys are not working, a 9 to 5 or certainly an 8 to 7 desk job under a lot of stress. They're working out, they're eating, and they're sleeping. And what else? And there's an expression, idle mind is devil's playground. The fact of the matter is, and I'm going to get a lot of flack for this, I know, but it's the truth. And if anyone's out in that field, they'll know. A lot of recreational drugs come in there. Guys are getting involved with, in my generation, we knew a lot of guys that were getting involved in Nubane was the drug.
The painkiller, right?
Yeah. So, it's the recreational drugs that are biting them in the butt, not the testosterone.
Okay. Okay. Interesting.
And again, you can do anything in excess. I'm not saying that's not the case, but really, you're probably more apt to harm yourself with excess aspirin use than excess anabolic steroid use.
Okay. So back to the other question I had, which is, what are some of the mistakes you see in the TRT space where, doctors are giving patients testosterone? Underdosing.
So one of the first things doctors do is they go, okay, well,
this is what happened to me.
You're at 400, and we're going to shoot for X, and whatever X is for that doctor is, let's call it 800 nanograms per deciliter of total T. That's what we're shooting for. We're going to give you what we would consider the difference. Well, your body is working on like a thermostat, and it'll just simply go, great. Now I have to do even less work. And so initially you might get a bump, and then your pituitary realizes, okay, no need to send as much luteinizing hormone to the testicles, and you drop back down to 400 again. Or sometimes even less, depending on the dose.
That's what happened to me. So I went lower.
Right, because you suppressed it.
Yeah, they gave me, so that's what I thought was really fascinating. I think the first time I tested, I was like, I want to say 412 was my number. And they gave me 150 milligrams of testosterone. On day 7, when we would retest, I actually fell down to 398, 406, and then they would just keep. Then they moved me to like 160, then 170, and I think when they finally got me to 180, which was right before I met you, I was still coming around 440 or something. But initially it was crashing me lower than when I even started.
So it has to do with the dose, and the timing of the dosing, of course. And you can imagine what I saw with like daily dosing of the gels and stuff, where it almost acted like hormonal oral birth control for females, where you've got a smidgen of something, but it's enough of a smidgen of estrogen, for example, that suppresses her endogenous production. That was what was happening to you. And that happens a lot with physicians who think that way. Okay, you have to, again, think of it like a thermostat in order to dose properly. And then, of course, you have people that, as I said earlier, either, a cheap date or an expensive date that might be metabolizing it more quickly. So that's probably the biggest mistake doctors make. And then the other one is, and it's part and parcel of that, shooting for a certain number. that's within the reference interval. You're no longer normal once you're on TRT. Okay, again, who wants to be normal? But those reference intervals are for people that are producing their own testosterone. We've known since the 1950s, and I'm certain of this, that in order to resolve the complaints that most people come in with, to get clinical benefit, in other words, you have to hit, and this is back in the 50s, they would use the total testosterone, at least 800 nanograms per deciliter, total T. Now, when I say hit it, I'm talking about maintaining a level above that. So that's the minimum above which you want to maintain. So that's the threshold, right? So if you're using cypionate, for example, on a weekly basis, that's the number you want to be at on day 7 or day 1, however you want to call it, the day you're going to do your injection, but before you do your injection. Okay, you don't want to drop below that. Now, I would argue that in today's world where we use free T, which is roughly, especially on someone using TRT, 2% of total T, I think you're shooting for, at least in my experience, for clinical benefit, the patient to be optimized somewhere around 28, maybe even 32 picograms per milliliter of free T. And again, I'm just using numbers here, right? I don't care what the number is. If you come in and you say you're feeling great and your free T's at 16 on day 7, I don't care to adjust it. Okay. But again, if we're using numbers, that's the number that seems to alleviate most of the symptoms that guys are complaining about. Now, again, I'm giving you guys' numbers. And for guys, the total T is probably going to be at least double high normal during the course of the week. Okay. For females, it gets even more interesting because they're going to be probably at triple high normal of that reference interval, right? To get to a therapeutic range. And it freaks physicians out, primary care physicians who aren't in charge of this, and the patients themselves, unless we warn them that, hey, this is the number you're going to see on your total. But again, their free T, females I'm talking about, will be usually within the range, which is, up to 4.2, say, picograms per milliliter. And again, who cares about the number? But I'm just giving you the number. Right. That's where they seem to, that's the sweet spot, the therapeutic threshold above which they have to maintain to feel better.
Wow.
Now I have a question. I'm probably the most ignorant out of the three of us in terms of like anabolic steroids and bodybuilding. And, I come from a little bit more of a sports background where I was told to just avoid them completely, right? I was wondering just for myself and for the audience in terms of like what the options are out there for anabolic steroids and what each one has in terms of their characteristics versus the other. You mentioned like DECA and testosterone, and like what are the other ones that are kind of out there, and what are sort of the pros or cons of all these things?
Great question. So there's a bunch of great steroids out there, anabolic steroids. And before I go in any further, so people use that term loosely, right? Steroids. Well, testosterone, estrogen, DHEA, progesterone, pregnenolone, they're all steroids.
Isn't cholesterol a steroid even?
Well, cholesterol is the molecule from which we derive the word steroid, like cholesterol, like steroid, right? So all these hormones that we're talking about, are made from cholesterol. So that's different than an anabolic steroid to which you're referring, right? A molecule that usually is either a testosterone molecule or often enough a dihydrotestosterone molecule that's been jiggered in such a way by removing or adding a ligand along the molecule so that when it goes into the cell, it operates differently, we'll say, than a typical testosterone molecule. And what we mean operating differently is typically, more of the anabolic properties will be emphasized, those that build muscle, accrete mass, rather than the androgenic side effects, the secondary male sex characteristics we call it. Accentuate the hair on the ears we get after we're in our 30s and stuff like that. The weird stuff that none of us likes, balding and stuff like that. So there are a bunch of different anabolics that have been developed. Unfortunately, we're limited as to what we can use in the United States. There are roughly, 4 that are used. There are more than that are actually legal. For example, there's something called halotestin, which I have no idea why anyone would ever want to use it. A lot of bodybuilders do because it makes you, and I'll put it mildly, kind of edgy. And if you're
powerlifters like to use that one, I heard. I guess it makes them aggressive,
ramps them up, right? Yeah. So bodybuilders, powerlifters is a great example. They'll use smelling salts to perk themselves up, if you will, right before a lift. Same idea with halotestin. With bodybuilders, it's more for, hey, I'm sucking wind here because I'm not eating prior to the show, and they want anything to get them through a workout. It's unfortunately really rough on the liver. And again, it can make you, edgy's an understatement, it can make you homicidal. So again, halotestin, I would say, hey, eschew that and have an extra espresso before workout instead. But we have some good anabolics that are useful for wasting disorders. I mean, that's what their standard, their indication is, right? Cachexia and wasting disorders, burn victims. So oxandrolone, used to be known as Anavar, is one of the best ones out there because not only is it anabolic in nature, it's also catabolic in nature. So you can actually put on muscle and lose fat at the same time, sort of the holy grail of what most people magical. In life would like. Yeah. Yeah, and it's it can be used in females too. It's one of those that's a dihydrotestosterone derivative, and it doesn't convert to estrogen. Therefore, it doesn't affect the receptors, for dihydrotestosterone. So it's what we would consider a clean anabolic steroid. It's also, again, very useful for females because it doesn't convert to estrogen. So if someone has had an estrogen-sensitive cancer, they can use it without fear of propagating cancer yet again, an estrogen-sensitive cancer. So in that way, it's a wonder drug. A lot of bodybuilders use it prior to a show because that's exactly what they're trying to do. They're trying to lose fat and hold that muscle. There's one related to that called stanozolol, which used to go by the brand name Winstrol. And that one is very similar to oxandrolone, except it also, one of the indications is for angioedema. So it gets rid of the extra water, the third space water, the kind of water you don't want, not the water that stays in the cell, but the water that's in between cells. And so bodybuilders like to use that a lot too, or track athletes like
that's what Ben Johnson got banned from the Olympics or whatever. Got his gold medal taken away for that.
And it makes sense, right? You would use that one over Anavar. Why? Because any athlete like that wants to carry as little extra as possible, yet still maintain the muscle mass and lose the fat, right? So that makes sense for track athletes to use Winstrol. Plus, I think it tends to pep you up a little bit too. That's just been my experience.
And that's you can prescribe that in the U.S.
Yes.
Okay.
You can prescribe an oral form. You cannot prescribe an injectable form. And I may not be the one to quote when it comes to the legal aspects of this. Okay. Because it might have changed, but that's my understanding is that, you can't do the injectable for some, I guess that's only for animals or something. There's some rationale behind it. I don't know. Okay. And by the way, you can't get an injectable Anavar either, which baffles me sometimes because I think it would be more useful in some ways especially if you ever had to use a higher dose, like for a burn victim. There's a lot of talk about how these are hard on the liver because they're oral steroids and they're alkylated a certain way. In my experience, I've never seen elevations in liver enzymes because of these when used the way they're supposed to be used. And this will be probably more helpful for the nerds out there. But AST and ALT are typically referred to as liver enzymes. And yet you can have elevated AST and ALT because of just muscle tissue breakdown. And so a lot of times people who are on anabolic steroids have more turnover of muscle, certainly, right? And so, look, that anabolic you're on is causing liver issues. No, it's not. And an easy way for physicians who are listening or anyone else to verify that is to get a GGT, which won't be elevated for muscle tissue breakdown, okay? And it's specific to, the liver, but also pancreas, biliary tract, et cetera. So you use that to compare and go, look, my GGT is well within normal limits, but my AST and ALT are mildly elevated. You can assume that things are safe. And there's other ways to prove that, by the way. You can do a liver ultrasound to make sure it's not too fatty, which, by the way, is one of the typical side effects. Probably the most dangerous thing about an anabolic steroid is fatty liver, okay? Which tends to resolve after you get off the anabolic steroid. And it all makes sense because what do anabolic steroids do? They help pack glycogen into muscles, right? So that they become
also do to the liver then, I guess.
Better later. But the next step up once the muscle's filled for the moment, the next step up is to store the energy in the form of glycogen in the liver. So you can build a fatty liver fairly early, and I'll keep rambling here. Let me just ramble a little bit more because I think your audience will appreciate this too. And I learned this from Franco Columbu way back in the day, God rest his soul. Bodybuilders, like I said, and especially back in the day, used to just want to get big. So you do a lot of lifting, a lot of eating, and a lot of sitting around. Well, you could very easily develop a fatty liver. And so they all knew after an anabolic steroid cycle to use something called, back then it was just inositol and choline. They're nowadays still considered pretty much a B vitamin, although they're still arguing about how to classify them. Now we add another amino acid called L-methionine, and we call them McCaps. 30 days of these McCaps in a high dose, where you're using 3,000 milligrams of inositol and choline and 1,500 of L-methionine every day for 30 days, divided all at once, and you'll get a squeaky clean liver.
Oh, wow.
Yeah.
Wow, fascinating.
And I say this because, I mean, fatty liver, the latest estimates is that 100 million Americans, that's a lot of us, have fatty liver, and yet there's no pharmaceutical cure. I don't care what they market it as, and I'm not naming names, but I'm telling you right now, we don't have anything to compare to these three simple ingredients that you can get over the counter.
Yeah.
Yeah, and not harmful.
All right.
Wow. Now, there are others. So back to your question, there's nandrolone, which used to be branded as decadrolone, which is an injectable steroid, great for just putting on mass. It's essentially anabolic without being catabolic as well, like stanozolol and oxandrolone. And I use for HIV patients, it's fantastic because you can put on 20, 25 pounds of extra weight in someone that unfortunately they can go through a bout of illness, and that 25 pounds can be a lifesaver. I mean, it's a no-brainer, and very little risk with. What are the risks with nandrolone? I say very little. According to the medicine, that elevation in lipids, the bad lipids, the LDL is supposed to be a bad thing, but again, for reasons we talked about earlier, I would argue that's a bunch of bunk. And so it's a no-brainer for someone with HIV who's underweight or even midweight to put a few extra pounds on it if it's not stressing the heart or something like that. So, and then the other one, which again I don't understand why you'd necessarily want to ever prescribe it, is something called Anadrol.
Oxymethylone, is that the name?
I've never written a prescription for it in my life.
I heard that was referred to. God, this is back in the 90s. I had this bodybuilder that worked for me, and they called it gorilla roids. That was the nickname they gave Anadrol.
Well, isn't that 5? Didn't you say 4? Or that's not 5 right there, right?
There's the
Anadrol?
That's 5 now, yeah.
Oh,
because I said there's 4 that make sense. Halotestin makes
doesn't
no
make
sense to
sense.
me.
Got it.
And Anadrol makes no sense.
And there are other ones that are legal. There's something called danazol, which is called an anabolic steroid, but I don't see anything anabolic about it. What I use it for, rarely, but I've still used it, is if someone's on TRT and their free testosterone is on the low side in terms of percentage, like it might be 1.5% instead of 2% for some odd reason, I'll throw in a little bit of danazol, which really wouldn't do anything except reduce SHBG, which is binding the total testosterone so that the free testosterone comes up. But Anadrol, you said it was, what did you call it?
Gorilla roids is what it is.
I call it dinosaur juice, man. I don't know why anyone would want to be on that, but it's for people that are really having a hard time putting on weight. The indication, I think, is for, I want to say pernicious anemia. And there's so many other ways to treat pernicious anemia than putting them on Anadrol, which, by the way, has a major side effect for a lot of guys. It doesn't convert to estrogen, but it seems to activate the estrogen receptor somehow, and it makes guys just absolutely, crazy. The so-called roid rage that people talk about, by the way, is typically not because of anabolic steroids. Now, halotestin can have that side effect to it, if you will. I'd say that has a profile that makes guys aggressive, no doubt. But it's really estrogen out of control that turns Dr. Jekyll into Mr. Hyde. The guy at the gym who puts on 30 pounds, all of a sudden becomes really red-faced and puffy, and then, at the water fountain used to be a nice guy, now he's a jerk. That's typically because he hasn't controlled his estrogen properly, not because of the anabolic steroids. And think about it. The guys that are the big yoke guys in the gym that are doing it right don't look like that and don't act like that. And as guys, we can talk about, well, why would he? He knows he's huge. He can kick everyone's butt in the gym. Why would he get aggro over anything? He's like happy-go-lucky. Right. Testosterone makes you feel that way. But anyway, that's the answer to your question. I hope. I mean, those.
Yeah, I have a follow-up to that. But
where does Boulderon fall on that? Like, we didn't
not that's considered contraband for humans anyway in this country.
Veterinary
equipoise, is what it's used for. Just like the injectable Winstrol is for.
Would you compare that to like is it more like Deca, or what would it be?
It is. It's got a structure similar to Decadrolone or Nandrolone, but it can convert more easily. Everyone says Nandrolone doesn't convert at all, but I think roughly 20% of it can convert to an estrogen. Boldenone can convert more readily to estrogen, but it doesn't come with the side effect that everyone dreads with nandrolone. We haven't talked about that. Yeah. Sorry, I skipped that side effect. Decadurabolin comes with, they call it Decadic.
Yeah. Okay.
Erectile dysfunction because for a lot of men, particularly the same ones that would react negatively to finasteride or dutasteride, Proscar, Propecia, and dutasteride goes Avodart. They don't produce enough dihydrotestosterone and have erectile dysfunction, which, by the way, is not as prevalent as you would believe based upon all the press. But it does happen. And so with nandrolone, you get conversion to dihydronandrolone, which is very, very similar to it's very, very weak in effect. So it binds to the receptor that DHT would go to.
Oh,
so
it occupies the receptor, so DHT can't go do its job.
Yeah, and so some guys will react to nandrolone with what they call Decadic, based upon the old brand name to it. Yeah.
Wow.
So I've also seen this rise in SARMs, and I wanted to see if you could kind of go over that in terms of what you've seen, the reasoning why people use them, and also like maybe like some potential, negative effects of that.
SARMs are not my favorite. Now, I say that pleading ignorance because I can't keep up with all the SARMs. Guys are inventing these peptides more frequently than I can study them. And I knew this was coming because when I was still in, doing my prereqs prior to medical school, I can remember walking down the building in the physics department, mind you, in CSUN, and they had all these pictures of peptides on the wall, these different hormones and whatnot. Why is this in the physics department? Well, because peptides are made like Lincoln Logs, I think they are, or not Tinker Toys, whatever. But the one that you could put together different angles and all these things. And the sky's the limit as to what you can invent with peptides. And these SARMs that they're coming up with, all these peptides typically are going into the cell and doing all kinds of things. We haven't thoroughly tested them. So there's a reason right there where you go, hey, be careful, guys, with what you're buying out there. Not only haven't been tested, but who knows how they're being made and what's coming with them, in terms of excipients and other, toxic constituents. And again, I don't mean to wave the prude button, but be careful.
But a guy like you has got to get almost annoyed seeing that, because I would think with all your extensive knowledge with hormones and knowing how much we've researched all these ones that you just talked about, there's so much more that we know about that compared to these SARMs, not to mention what we know as far as side effects and stuff, but also how much more effective like regular hormones are. So like, why would you want to take more risk for less results? Like this, it doesn't make sense to me.
Well, and that's really what I come to at the end of the discussion, practicality rules. We did a study, and a former partner of mine, with some athletes that volunteered and a supplier of Ostarine. And it wasn't an IRB, it was just a voluntary deal where guys said, hey, let's try this. And it was, now the dose was by the manufacturer, suggested at 25 milligrams, which I think is still what they use. And to your point, they had less result than even being on TRT, and certainly than an anabolic. And the side effects were worse if you want to consider the effect on the lipids worse. So the HDL plunged even more, the LDL went up even more, and you don't get the same benefit. Why? Now, I speculate it's because of good old American values of, hey, I don't want anybody telling me what to do. And people, and I get it, I'm a registered libertarian, don't want to have to ask a doctor for a prescription. And so they get these SARMs and the way they want to get them, and I God bless them. But again, to your point, why not do what works? It's okay. I get it. It's what we have to deal with. I make a living at it. You have to go through the gatekeeper, and qualify to get this particular substance and all that. But when it's an inferior product, I argue, okay, this is not the right battle to fight. Go somewhere else. Now with the new SARMs though that I'm ignorant of, there's a lot of them. Even things like Rad 140 that have been around for a while. I got people saying, wow, this is great. And I just don't have enough experience with them to tell you, oh, yeah, it is better than, say, oxandrolone or something. I will say that a lot of those guys that test out these SARMs, though, have never done an anabolic, the ones that I talk to. And also they're often stacking. So what was it, the RAD 140 or was it the RAD 140 and the ibutamorin and the BPC 157 or better yet, the thymosin beta 4? What did what? And this is a big problem in the bodybuilding community because we're stacking now, unlike we used to in my era, where again, because we couldn't get it or we couldn't afford it, we did one thing at a time.
Yeah. Let's talk a little bit about how testosterone is administered, because the old way, which is, from what I've read, the best way, which is injecting. So you inject it intramuscularly, but then they've come out with creams that you rub on your skin. There's, I think they're called, I don't know if I'm pronouncing it right, trouches. Am I pronouncing that right? Or pouches? They're like,
I call them troches or troches.
Troches. There you go.
Troches, I think is excuse me, I think actually the way people say it, but I think if you look it up, I think it's from the French. I think you're supposed to say
troche.
Something like that.
Yeah. Okay.
The common pronunciation is troche, so let's just stick with that.
So, and I guess it's like you put it in your gum and it absorbs, through the mucous membranes of the mouth or whatever. There's tablets. Like, what's the best form of administration from getting the testosterone levels where you want, getting people to feel the best type of, context?
And safest.
Yeah. So as always, it's individualized, but in general, I would argue that for a male, the best way is through an intramuscular injection of a esterified form of testosterone, like a cypionate or an enanthate, which are pretty similar. It works out on a weekly basis. It just so happens it works out pretty well for most patients. So you just remember, okay, every Sunday I'm going to do my injection. Mm-hmm. We have another ester called undecanoate, which is proven to be just a hassle to try and even find it. But it's a much longer lasting ester. They also use them orally, but for the injectable, which would mean, okay, presumably you could maybe inject every 3 weeks instead of a week. You just can't get it. And I think it might have something to do with one of the warnings is that it can create, what's the word? I think the warning says it might cause a thrombus, which is going to scare a lot of people, including docs, away. And I don't know why that's on there, because that opens up a whole other can of worms about testosterone, because that's one of the things that a lot of doctors claim also, that, you can increase your risk of stroke. And this rise in hemoglobin hematocrit is evidence of that. If you talk to a hematologist, they'll laugh. Okay, increased viscosity does not mean that you're going to get a stroke. And while we're on the topic, or I brought us on the topic, I'll say 2 studies that I'm aware of will clearly show that depending upon the studies, either 6 months or 9 months in, for those 6 or 9 months, if you have a pre-existing issue with blood, a coagulopathy, an issue with clotting too easily, then it will exacerbate it for 6 to 9 months, and it goes back to the normal risk of anyone else, right? So again, did testosterone cause that? No more than LDL causes coronary artery disease. No, it can contribute to it if you have a pre-existing condition, but these are typically very rare. As a matter of fact, the standard human being has what we call is heterozygous for a clotting disorder, Leiden factor 5. So it's normal for most of us to have one Leiden factor 5 gene and not. So the other coagulopathies are even more rare. Okay, and those are the ones we're talking about. So my point is, the chances of you having an issue with clotting when you take testosterone are very, very low, such that anyone who administers it typically doesn't even test for these things. Okay,
interesting.
You could argue that you should maybe because of the slight increased risk, but even then, those that have the coagulopathy, the increased risk of a thrombus forming at all is also very, very small. So again, I think that's why we ignore it.
Let's talk about the change in quality of life that a man, and we'll get to women because I really want to get to that because I think there's way more stigma with women using testosterone, of course, than men. But
amen. Let's
start with men for a second here. A guy comes and sees you, low testosterone, signs of low testosterone. He goes on therapy. What kind of changes in quality of life do you typically see with? And I know it's an individual, but what is typically seen with somebody who goes on TRT?
The basics are, hey, doc, I've got low energy, and I shouldn't say low energy because the magic word is really decreased, whatever it might be. Because one of the reasons why we don't see patients as soon as we should is because we've all seen the guy who's bouncing around the walls, right, or off the walls. He's got natural high energy, and he figures, he looks at his buddy Ralph and goes, geez, man, Ralph's fat and out of shape on the couch. I'm still working out. I got tons of energy. Nothing wrong with me. It's just old age, right? He shouldn't compare himself to anybody else. He should compare himself to him and say, hey, man, how am I doing compared to 10, 15, 20 years ago? Do I have a decrease in my libido, my energy level, my sense of well-being? My ability to change my body composition, which the first three are personality traits, you could argue, right? And influence therefrom. But change in body composition, that's not, indirectly driven by your personality. Do you get your butt into the gym or not, right? But that one, like, you got a guy who, especially a successful athlete, who knows all the right things to do and just keeps saying, well, I'll just try harder. I'll do more of this. I'll do more of that. They're the last ones to come in. And really, they're the ones that would probably benefit more than anybody to come in sooner. So those are the, I guess I call them 4 things that most people complain about. Now, connected to that, though, an increased sense of well-being, that can affect your sleep. When you wake up in the middle of the night and think about your 2.3 kids and a mortgage and go, oh my God, how am I going to get through this? When things are going well, you go, shut up, brain. I'll handle it like I always do when I get up in the morning and kick butt because I feel good. I'm wake up feeling like I'm kicking butt. When you have the flu, for example, you don't wake up and think, the world becomes a horrible place for 10 days, right? Why? Not because the world's changed. When the flu goes away, the world's great again, right? It's because you don't feel well. And when you're off because of low T, you wake up and you start ruminating about that. Like, oh yeah, how am I going to make that car payment? And you think about it, you go, hey, I got plenty of time to think about that. Why do I need to think about it in the middle of the night? They're going to send me a nice little letter telling me that my car's going to be repossessed long before it happens. You get my meaning. These are the things that come along with low testosterone that people don't even think about. And once they start on therapy, they go, hey, by the way, I didn't talk about it the first time I saw you, but boy, I'm sleeping a lot better now too. And there's things that come with that because they're working out more often. And of course, that helps you get into a deeper sleep. Things we know that come with the other things that you're doing that can be indirectly because of the testosterone therapy. But those are the main things.
So feel better, higher libido, greater sense of well-being, confidence.
Yeah. Okay. And again, compare yourself to yourself, not to your buddies. Think about it. When was the last time you played poker on a Saturday night with your buddies? The little things that start to go away, you say, wait a minute, I'm doing fine. I'm keeping up with my business. I'm doing all the things I used to do. Well, wait a minute. No, I am keeping up with my business, but I used to be able to do that. And like I say, see my buddies for an occasion, a monthly poker match. Those things start falling off. And again, it's for the people that tend to be tougher to begin with that, rationalize that stuff and probably postpone their
I was
trip.
that guy. I was 100% that guy. I waited longer than I probably should have because I thought, give myself more time to probably naturally bring it back up. I was still kind of working out and being somewhat consistent with that. So I'm doing better than this guy. Like I kept justifying in my head like that. But the 2 big things that I noticed that what finally kicked me into gear to go finally do it was just my drive to even want to get in the gym. For most all my 20s, I remember thinking about my workout the night before because I couldn't wait to go lift. I was excited to train. I was in love with it. And I had lost a lot of that, and yet I was still disciplining myself to come in and go. My desire to do it, I had lost. And then, of course, all the other ones you touched on, I noticed all those things dramatically increased. The other thing that was really pushed me in that direction is as a trainer and doing this as long as I have, I know how I need to eat. I know how I need to train to change my body composition, and pretty quick too. I can get it in there. And that's what I was really getting frustrated with is 1, the drive to get in, and then 2, when I was in and I was being consistent and I was eating the ways, my body just was not responding the way it had in the past. And that's what broke me down. If I go, okay, I think I need some help. I don't think I'm going to be able to figure this out myself.
But what about the other thing I was talking about? Did you also look around and go, and I know you'll answer this, so I'll do humility. I'll tee that up for you. But you look around and you go, well, I'm still kicking ass here. Well, I'm still way better than the 95, 99% of the people in there. So you go, and again, it's not to say I'm great, but just to go, okay, well, maybe it is just because I'm getting older, or this is just what I'm supposed to expect. And to some degree, like we talked about earlier, it is normal, but it's not what you have to do, you have to suffer through, right?
No,
Did you
you're
compare
100%
yourself?
right.
Yeah.
That's exactly what I did. Was, I'm approaching 40. I'm the youngest of my friends, so all my friends are in their 40s, and I'm looking at, even though I'm feeling all these things, not feeling great, I don't have the drive, body's not changing, I'm still in a better position than all of them, and so I'm going, oh, okay, well maybe it is. I'm just getting older, and all those things are just inevitably going to decline for me.
Yeah. So let's get back. Let's talk to about women now, because I know women can also suffer from low testosterone and benefit from testosterone therapy, but is a huge stigma around treating women. They're afraid, of course, of turning into a man and growing a bunch of facial hair and all kinds of weird stuff. What are some of the symptoms that women go through, and how do they feel afterwards? Is it very similar to what men will feel?
Yeah, this is actually the saddest part, and we're actually making a very concerted effort to reach out and appeal to women more, because actually when I started, I had more women in my practice than men. But I think maybe because of the stigma that you refer to, they just they don't get the right push, they don't get the right answers, and they're kind of left in the lurch. The symptoms they suffer from are the same as for guys. That lack of libido, energy, sense of well-being, call it joie de vivre, whatever you want, and the ability to change their body composition falls off the same way it happens with guys. The problem is, we were kind of reared to look at the hormones, the so-called sex hormones, right, as testosterone is male, estrogen is female,
right,
when in fact we both have the same hormones. Okay, just different ratios. We men carry estrogen and testosterone in our bodies, just more testosterone than estrogen, and the reverse for females. So that one's very unfortunate. And like I said earlier, I see urologists picking up the ball for the men, but I don't see OBGYNs picking up the ball for females. And so, like I say, they're kind of left in the lurch. And there's a lot of misconception out there. Oh God, I'm going to grow a beard. Oh gosh, I'm going to turn into Arnold Schwarzenegger in terms of my body composition, which, I mean, if you just think about how ridiculous that one is, I mean, Arnold, like him or not, you had to work for that. It's not going to happen overnight, man. You got to put in some effort. Any bodybuilder will tell you that. And so, but they're legitimate fears, because also there are doctors that are writing protocols that are not aware of the potential side effects. And, while men and women have hair in the same places, women just a lot less of it typically, depending upon their phenotype, et cetera. That's a fear, because women don't want to have facial hair for now in this country. I don't think they ever have in the history of civilization. But I mention that because, you look at, 16th century paintings, and, women were kind of buxom back then, whereas today, or just 20 years ago, Twiggy was supposed to be the ideal body type. So things change. But anyway, as of today, women don't want to have beards, right? And so that's a fear. And while it will not cause a beard, it can, and it's, by the way, it's not the testosterone that will facilitate this extra growth. Is something that testosterone gets converted into, called dihydrotestosterone, that it's the fly in the ointment. Mm-hmm. So and by the way, like I said earlier, unless it's a very unusual female, she's got 2 or 3 somewhere on her face, right? Mm-hmm. Like grandma did when she was 35, they appeared, but you didn't see them until at 75. She says, I just don't care anymore. I've lived long enough. You take me as I am. Yeah, she stops plucking them. Then you notice them, right? Most of the females will have some of this, even if it's just sort of sideburns. My point being that it's driven by dihydrotestosterone, of course, first and foremost by the genes. And it's not the testosterone, but we can block the conversion from testosterone into dihydrotestosterone. You don't have to suffer from these side effects. And unfortunately, we do fix a lot of bad haircuts when it comes to female TRT, because they'll go to a doctor that hasn't really given it anything but short shrift in terms of study, and they put them on testosterone. They go, oh my God, that was a disaster. Yes, I love the energy and I love the libido, but my God, I got acne, which is also driven by dihydrotestosterone. And I don't think either sex likes acne, right?
Mm-hmm. What about the low voice? What's the mechanism there? Again,
dihydrotestosterone is what drives that. Dihydrotestosterone is 2 to 5 times more potent than testosterone in terms of potency and depending upon the receptor, right?
It's a masculinizing hormone, essentially.
Yeah, I mean, that's what we refer to it. The male sex, secondary sex characteristics are driven by that particular hormone more than any other. It's an androgen, And I mean, that's an issue. So the good news is for those that are on it and are not and are suffering with some of these side effects, or those who are planning on getting on it and worried about them, we can stop that conversion and therefore prevent the side effects. Or you really kind of have about a 6-month window in which you can reverse them, I've found. So if someone's starting to notice, oh, my voice is getting deeper, because of the thickening of the vocal cords, then we can put them on something to stop the DHT.
Oh, interesting.
And you got about a 6-month window. And by the way, this is what I tell all patients: you can stop, and that extra hair growth will go away. Okay. And usually I'm stopped mid-sentence and go, yeah, you told me that, but never mind, I'll just get more laser. Well, okay, wait a minute. I also told you don't have to get the laser either. If we put you on a substance, it's usually finasteride or dutasteride. The older docs used to use something called spironolactone, which is a diuretic, a potassium-sparing diuretic. They used to use it ubiquitously for females in acne because they know that as a side effect, it blocks, and only works in females, by the way, dihydrotestosterone formation. I don't think anybody needs to be dehydrated necessarily. I mean, unless they have hypertension, and we can use it as an adjunct. But most athletes, that's one of your worst enemies is dehydration. So I don't use the diuretics anymore. But finasteride or dutasteride even works great to block dihydrotestosterone. Again, people think of it as a male drug, but it works the same in a female. And
so a female walks in and she complains similar to like maybe what my complaints were: low energy, mood, libido all down, body composition struggling to change. What does and I know of course there's a variance, but what does kind of a normal dose of testosterone look like for a female to help her rebound from all those things?
Roughly 1/10 the dose of a male is what it works out to. Yeah,
so like 20 milligrams or something like that, right?
Yeah, we'll use a testosterone cypionate, 20 milligrams per ml per week.
That's a tiny amount.
Yeah, well, and that's why we got to have it in a different strength, because to be precise is difficult with 200 megs per ml. So we have to get them a different strength, and actually we can get away with 50 megs per ml and just use 0.4 mLs, and it's precise enough to be accurate. So that's pretty much the secret there. And by the way, we were talking about the different delivery systems. For men, without a doubt, clinically, you're going to see much better result with the injectable, anything that's esterified. With women, because it's a smaller amount of testosterone required, is what I imagine part of the reason is anyway. You can get away with the creams and gels, or even orals, because again, the argument is that less stress on the liver. I don't think there really is. I mean, you could argue with methylated test, one of the original testosterone orals. It was hard on the liver, but any of the others, I don't think you have an issue with. But given that argument, you want to select one of the others first. But there's still the drawback of you got to put it on, wait for 5 minutes for it to be to dry anyway, and then another 25, let's say, to have it be fully absorbed before you can go, swimming or exercising or whatever. I joke I dropped my candy by not investing in Sephora because my wife puts on a cream every day, several creams. I'm like, oh, geez. And so, male or female, some are like, okay, what's another cream? Big deal. But there's some that say, no, hey, man, if I can avoid one more cream, I'll do the once-a-week injection. But in terms of efficacy, I don't see much difference for a female, whether they use an injectable or a cream or a gel.
So they're taking about 20 milligrams. And then what else are they taking in order to block the DHI? DHI. I thought testosterone. What'd you call it?
DHT.
DHT, dihydrotestosterone. Yeah. Sorry, I'll stop with the abbreviations.
No, it's okay. It's okay.
I don't put them on a dihydrotestosterone blocker. We call it a 5-alpha reductase inhibitor. Typically, unless they complain or they've had experience where they say, oh, I did it with this doctor and man, I got acne, or man, I started getting hair in the wrong places. Then I'll say, okay, well, we know that's in your genes. That's what's going to happen to you. Let's put you on from the get-go.
Oh, okay.
But it only happens in about, say, 20, maybe 25% of the females, or males for that matter, that have side effects. So I don't put people on immediately, but we have a feature in the charting system. It's patient health record, I think it's called, where we can message. So I say to patients, hey, as soon as you see anything you even think is a side effect, communicate with us and we'll put you on right away. But, if we start people on it, then based on what I just said, 75 to 80% of the people are taking it that don't even need it.
So what does the process look like? Let's say somebody's watching this or listening and they're like, okay, I have some of those symptoms. I suspect maybe I have low testosterone. I'm eating right, exercising, getting good sleep, but I still feel this way. What does the process look like? They contact your facility, and then what kind of testing do they need? What does that whole thing look like?
Well, in order to get a prescription, first of all, again, fortunately, unfortunately, testosterone is considered a controlled substance. It's a Schedule III controlled substance. And so you have to have a prescription for it. In order to get a prescription, you have to have a relationship with a doctor. And in the state of California, you have to establish a relationship with a physician, which involves a history and a physical exam. So those are the hoops you got to jump through. Okay. You have to see a physician. I say see. These days, you can get a surrogate physical exam from another physician. They're called a surrogate, so that your primary care physician you could go into today, and then I could use that physical exam tomorrow, trusting a fellow physician, and then you and I have to talk about what's going on. There has to be a reason for prescribing this. Mm-hmm. So we talk about the symptoms. Like I said, it could be that it has nothing to do with your testosterone. There's so many ways. I mean, there's tons of ways to get a headache. There's tons of ways to have low energy and low libido.
Sure.
So we got to look at typically some labs to help us guide the decision-making process, the evaluation. But it starts with, as I said, you and your symptoms. What's going on with you? What are your we call them chief complaints?
Awesome. So they do that, then they get on, and then I can only imagine that because I've known several people who've gone on TRT and they're just rave about how they feel. I can imagine that the stick rate, in other words, the amount of people that work with you who stay on, is probably through the roof. Do people tend to fall off, or they tend to stick around once they feel the effects?
Yeah, someone who was a crummy salesman because I hated rejection. This is a great profession to be in. Yeah, we have very few people ever drop off because it works great, man. I have a great job. I really do. I don't see sick people. I see people that want to optimize. I mean, sometimes we see people that need to be pulled out of a hole, and that's very, very rewarding. I have a buddy, Joe Rivera. He won't mind. He put all this on not Instagram, but YouTube. His mom came in on 26 meds. 26 medications. She was taking medicines for medicines.
Yeah.
Okay. And we got her down to 4, 2 of which were only temporary because of something else that was only temporary. And we got her off. And she came in on a walker, and then ended up, doing the pool and hiking, miles and stuff. It was really, really rewarding, not just because Joe's my buddy, but because you watch an individual who's being overly medicated. And that was an interesting conversation with her physician too.
I speculate your business to explode from this conversation, because when I started talking about my journey on the show openly, and I started to get, and I was blown away by this. I told the guys this, that my entire career as a personal trainer in gyms, this is 15 years ago, when I was working in gyms, I never met men under the age of 40 or 50 that would complain about low testosterone. When I started talking about it on the show, I was getting tons of DMs, and from young men, from men in their 20s who went and got their blood work done and were telling me their total testosterone was 170, 205, like ouch. 25 years old, 23. I was blown away by how many young men were that. And then Sal talks about the studies that have been coming out about how much that's been declining. And I find that really fascinating that you're seeing, I expect that in a 50-year-old man, right? But not to see that in young men in their 20s. And I've been telling them, listen, I'm not a doctor. I don't know what to tell you in this situation, but I do know that we'll be talking to one on the show about this. And so I know there's a lot of people who have been waiting for this conversation, because I know it's helped me out tremendously. And I had no idea how many young men were struggling with this.
What's interesting about that is, the age level has dropped for those that are definite candidates for TRT. Now, you don't necessarily want to go out and check your testosterone levels. That's kind of a no-no. I mean, an engineer would do that, but a doctor is counseled against that because you don't want to open up a can of worms that doesn't need to be opened, because you don't treat numbers. But most of the time, people don't wake up and say, well, gee, I better check my testosterone today. They check their testosterone because they have some complaints. Right. So it does kind of tie together that some of these 20-year-olds do have low testosterone, and there's a reason why they have the symptoms of it, and there's a reason why they checked, et cetera. What's also interesting about that is, in my experience, it appears that stress is the big driver, and it makes sense medically. Arguably, 300 years ago, when life expectancy on average was like 30 years old, life was still different. And that average was driven down by, infant mortality, early death, that sort of thing. But, we're herding sheep for a living. Stress levels are pretty low. You're worried about an occasional wolf. And, that's, if it does happen, it's, maybe once a month or something like that. And that's what we're designed for, acute stress, not chronic stress. You wake up in today's world, and I'm not whining, but even my dad will say, your dad told you, I'm sure, same as mine. He went to and from school,
uphill both ways
in the snow, ate dirt and lived in the shoebox, for the first 20 years of his life. He'll say, yeah, you guys have it tougher than we do. And none of us here is whining, right? But it is a fact of life. And I see it in 20-year-olds. I mean, just look at Hollywood. Kind of maybe a funny side note. I got guys that are 20 years old with ED. Yeah. It's not because of low testosterone oftentimes. It's because they believe what's on that stupid box that says that you're supposed to be able to, and pardon me if this sounds crass, but you're supposed to be able to take care of, like Casanova, 5 women at one time and do so for 5 hours. And they're like, oh my God, really? That would freak anybody out. And so there's some mental stuff going on there that adds stress that can affect your ability to get an erection. Yeah. It drives testosterone levels down. And so in my early part of the career, I would say, well, this is stress driven. You're 28 years old. This doesn't make a whole lot of sense. I do see this, low testosterone in a 28-year-old. But why don't we think about some ways to lower stress? Well, some people put even more stress on the situation, because what do you do if you've already got 2.3 kids and a mortgage? You're going to go to Bali and become a beach bum, to lower your stress levels? That's not an option.
The real problem.
Now, the cool thing is, that being said, in a 26, 28-year-old, you have some other options besides TRT. So you can bring that 2.3 kids to a full 3 by preserving your fertility. In other words, you can raise your endogenous production, because your testicles are usually still working just fine. It's just your brain, because it's stressed out, is affecting your pituitary, which is right below the brain, sending a signal to testicles to do their job. So we can give them something called HCG, human chorionic gonadotropin, no more abbreviations, and other things like off-label use of Clomid, or better yet, enclomiphene, which indirectly gets your pituitary to send a signal to testicles to make more testosterone. So we have, sort of a bridge gap there.
So is that what's more common practice then for you? If you got a 25 or 28-year-old young man that came in, complained of that, before you would say, hey, let's do 200 milligrams of testosterone. Let's first see if we can get this up with HCG or Clomid first.
Well, that's what I used to do back then, and I still do. I mean, I give them the option because it really gets down to practicalities. Medicine tends to want to let the body do what it wants to do. And again, the biggest argument I have there is, well, that's great, but eventually we die. So, the whole anti-aging movement is, and get sick in the meantime too, is to try and improve the quality of life and get the best of what Mother Nature gives us and get rid of the worst. So my argument is, look, by the time you're 50, certainly, more than likely, odds are you're going to be on TRT, right? If at 30, you're having issues already, I want you to have the options. Even for some, it's just a mental aspect of, even though we are dependent upon air, food, and sleep, and for some of us other things, to live an enjoyable life, for some reason, having to do testosterone once a week is something you go, wait a minute, I don't want to be dependent on anything. And I get that psychologically. But to have a choice is nice. But I'm not going to necessarily counsel a 26-year-old, hey, you have to do it this way. If they've got abnormally low T, I certainly will suggest to them, just because it makes life easier, not just mentally, but if they want to father children, it's easier to maintain fertility than to try and regain it if you lose it, Right. Even though I would argue even that really these days is not a consideration. I mean, it is, but I can say this for sure. I've never had anybody lose fertility that didn't regain fertility for physiological reasons. I've had people for psychological reasons back in the day when we'd pull you off T and say, well, let's just hope it comes back, that after 9 months I'd forget about it. But these days, even while on TRT, if someone, which doesn't happen that often, loses their fertility, they can regain it by just jumping on some HCG, for example, human chorionic gonadotropin, to get the testicles to jump back online and get the sperm flowing again.
Yeah, that's great advice, because I feel like, a 25-year-old, I think the fear that I would have if I was in your shoes of just right away prescribing him testosterone is, that may mask all the other issues that he's got going on. Maybe he does have stress. Maybe he does have a lot of other bad habits that are causing some of that too. And just by simply elevating those for him may make him think that he's better, but he's really not addressing all the root causes.
Well, you bring up another issue that I wouldn't necessarily touch on, but since you bring it up, yeah, with those patients, invariably what I'll do is recommend something called an MRI of the head. We want to see if the pituitary is damaged, has a tumor on it, is missing an empty cell, we call it, because that can be an issue. We can also do some other tests because there might be an extra X chromosome, Klinefelter's disease. So we want to find all the possibilities because, again, at 28, it's unusual. Although, again, for stress reasons, we're seeing it way more often than we used to, even just 20 years ago. But in a 58-year-old, you go, well, okay, duh.
Yeah.
And so, you follow what's called a differential diagnosis where, if you see a hoof print, you look for a horse before you look for a zebra. You follow the things that make the most sense. But in a younger patient, you want to rule out some genetics. You want to rule out some enzyme issues where they might not be converting. I want to call it CAH. And then these issues with the pituitary. So that's part and parcel of evaluating someone who's a younger candidate for sure. Okay. Now that said, what happens if you do have it's called a pituitary microadenoma? It sounds scary. It's just a fancy way of saying you have a little small tumor on the pituitary, which by the way is rarely malignant. It's just a growth that's messing with your production of luteinizing hormone, right? What if someone says, well, okay, that's great, but I don't want you drilling, a hole usually through the roof of the mouth and taking that thing off. I don't want surgery. Then you're still back to square one, but at least you have a reason. And I think that's to your point. But also to your point, are there things that are typically deadly that come with low T, meaning that are driving it that you might miss? No.
Okay. Interesting.
So it's again pretty safe what we deal with.
Well, Dr. Rand, this is the first time we've wanted to, or actually worked with any hormone replacement therapy facility. There's been lots of people who wanted to work with us, talk with us. We did our homework. We chose working with you because the information you already have out on YouTube, the way you talk about the way you do, we really appreciate it. So it's great. And we do get tons of questions and DMs on this. It's like a big thing, especially when Adam talks about
I'm tired of trying to answer them. So
yeah, so
you brought a lot of clarity for me.
Yeah, so
too,
we appreciate you coming
great.
on the show, and we appreciate this, moving forward, because we'd love to have you back on answering specific questions at some point and just talking to our audience, because this is definitely a big issue, a quality of life issue.
Well, I have a lot of fun doing it because, as with anything, it's like, I don't know, when you buy a new car, then all of a sudden you notice how many people have that same car on the road, right?
Yeah.
Not exactly a good analogy, but, I just figured everyone knew this stuff, more or less, and then we got to talking about it, like you said, on some of those YouTube videos, and you find out how many people go, wow, I didn't know that. I didn't realize that. So it really has been a lot of fun. And doctors live, I don't care what anybody says, doctors live for this, right? We want the pat on the back. Hey, thanks, doc. I really feel a lot better. And so it's been a great source of pleasure for me and everybody who works over on my team. I mean, it's a great job I have because you see a lot of happy patients, maybe not on the first day, but 90 days in, they come back and they go, doc, I feel so much better because of this, that, and the other. And we actually do get Christmas cards, every year. Hey,
That's
thanks.
awesome.
I had another great year. So
well, you did give a great analogy earlier about it being, the stigma around it being very similar like the marijuana industry. I just think there's still a lot of people around it that just think that it's, testosterone is this scary hormone that, you're doing drugs if you do it, and only these bodybuilders, and of course they attach it to the bodybuilders that died and think that it's because of that, or that you're going to beat your wife because you take testosterone. I mean, there's these awful stigmas that have been around for a long time around it that are still there. So no, I think there's a lot more education that needs to happen around it. So I'm excited to have you come on the show.
Yeah.
Well, to that end, just to add another tidbit before we sign off. I mean, the wife beater thing, the roid rage thing is really, like I said earlier, I think it has to do with excess estrogen, making you moody and irascible rather than anything else. Excess DHT can make you edgy, but not that kind of roid rage type stuff. And that goes back to, the problems with so many things comes with mismanagement, not doing it the right way. Right. And as long as you keep the estrogen down, it's not going to turn Dr. Jekyll into Mr. Hyde. But what I tell people is, if you're already
an asshole,
and I won't name names. Well, let's just use that.
If you're already an asshole, you're just a bigger asshole.
Exactly. Perfect. I couldn't have said it better. It's not going to turn you into one. So that's the only caveat I would say. For some people, maybe it's good that you let a little air out of their tire, but they were that way their whole life.
In other words, don't call Dr. Rand if you're an asshole.
Please refrain.
No, thanks again. Thanks for coming on the show.
No, my pleasure. Really, my pleasure.
Thank you.